Hi. Thanks very much, Richard and John, for that great introduction and couple of presentations. So, yeah, we're sort of rapidly sort of moving on to the next sort of stage. And I also say that if you've got any questions at all, then if you pop them in the Q&A feed, then we can either answer those if they're relatively easy as we go through on the chat, or I can pick those up at the end. We've already had some pre-questions that were presented to us, so we've had a little bit of a think about how to do those. So yeah, I'm Monica Jones. I'm the Population Health Management Lead for the Yorkshire Number Care Record. I've been doing this on secondment for the last couple of years. When I started, I was Director of Information Services at Rotherham Foundation Trust. I now work for the Health Data Research Hub for Cancer in Leeds, but continue to work on the population health management. There's quite a lot of sort of overlap between these things, particularly as we chose cancer and urgent care as our first two sort of pathways for looking at. Okay, next please, Rebecca. So there are three main aims, and some of you will have seen these before, but these are essentially the domains that we've focused on over the last couple of years in terms of building our capability. And we refer to this really as capability building because, as you saw from Richard's slides, it's about joining up our system of systems, not saying that everybody's got to use exactly the same sort of electronic patient record or clinical systems, but actually by using the technology that we can actually join those up. So that's very much the middle strand here, that better decision making, saving time in our integrated care record. And then on the left-hand side, well, my left-hand side, then going back to what John said on his intro, that we want to get people actively involved in their health and well-being, and in particular, population health management sort of focuses on these things around sort of more informed decision, improving self-care and management, particularly if people have got a long-term condition such as diabetes or cardiovascular disease. And then finally, it's that better planning of services and prevention, and around that improved intelligence from large-scale data sets to improve population health. So if you're looking at a population of 5.8 million people over the region that is Yorkshire and Humber, then actually there's a huge benefit in bringing those things together so that we can actually improve the services and the systems together. Next, please. So what do we mean by population health management? You've seen the definition that John showed on his presentation. That was the one that we co-developed, and the feedback from our citizens of Yorkshire and Humber is that they want something that is very clear to understand. But underneath that, then there are some complexities within the system, and I tend to use this diagram, this sort of feedback loop really to try and describe the component parts of population health management. It is by no means the only way of looking at it, but it's certainly the model that we've used. So there is something about knowing who your population is. So of our 5.8 million citizens, where are they? What kind of sort of uses of the system do they have? What kind of interactions with health and social care, but also sort of what conditions do they have and what are they living with. And classically we do population segmentation in order to do that. We then can identify sort of where care gaps are, and that's probably where the clever sort of analytics comes in, and potentially even using machine learning and AI. I won't say too much about that. Algorithms haven't had a particularly good press over the last few months, so but it just shows how important it is that actually you have patients and the public involved in everything that you do, that you actually test out any models. We then sort of move on to stratifying risks, and classically we've done risk stratification in primary care by looking at, let's say, the top 2, 5 or 10% of the population. Those people are at most at risk of hospitalization because of their underlying conditions, you know, and that's become even more apparent as part of the COVID pandemic, that those people who've got underlying conditions such as diabetes, hypertension, etc., you know, are likely to have poorer outcomes. And then we engage with the patients, make sure that everybody knows what's happening. We might set up new programs of work to manage that care and to measure those outcomes. So you can see then we go back around the loop. Okay, thanks. So what have we done during sort of 2020, or since we started in 2018? We finalised the build and test of our population health management platform. I refer to it as the data arc. I like the analogy of a data arc from a you know, safety and security, that we can manage to have structured data coming in. The animals come in 2 by 2. We have Noah with his IG staff standing on the bow, and actually sometimes we will need to keep some parts of the data away from others. You know, sometimes you've got to keep the lions away from the zebras. So we've proved that integration into the wider anonymized flow, and we've onboarded 2 major NHS users, both in Leeds and Bradford. And we'll be hearing a bit more about that from Kuldeep and Jeff's presentations, which are coming next, because, you know, we can talk about this from a very sort of ethereal sort of perspective, and so we want to hear from the users. We've implemented a service management tool, and we can, yeah, and Richard will talk a bit more about that. And we're just making sure that we've got the IG. We also have had the first academy and upskilled 40 Yorkshire and Humber delegates, and we've got a presentation later with some of the feedback from them as well. Okay, thanks. So what are our future plans? We're working very closely with NHS Digital to be the first adopter of the National De-Identification Solution, making sure that we're also compliant with the national opt-out, and refreshing our academy offer, developing our communities of practice, building the platform roadmap, and making sure that actually we've got we're returning value to the NHS, because, you know, I certainly know from my experience working in the front line of the NHS, sometimes you feel that all of this data is just going into a black hole. It's going to the centre and you never get anything back. And so actually we need to address that, and we need to make sure that we're sharing it, and that we are returning that value to the NHS. Okay, thanks. Next. Yeah. Right. So you have to have one architectural diagram, and this is it. I'm not going to go into the minutiae of it. You'll have access to the slides afterwards. But essentially, you can see that the data comes in from our system of systems. On the left-hand side, it comes into our population health management platform. It's got analytics services, integration services, and then we've got a set of sort of what we refer to as products. And I'm going to show you some dashboards, which are examples of those. And then I think the key things at the top, just before we go on to the next slide, is around the people who are doing the development of those data engineers, analysts, and the people like those who have come through on the first academy. And they are real people from across Yorkshire and Humber. But then the people who want to be able to use and consume that are commissioners, health providers, clinicians, health and social care workers. Okay, next. So these are just a few examples of some dashboards of that we've got. We can do more than just dashboards, and you'll actually hear from the 2 presentations that are coming next the type of analytics and modelling that has been done in Leeds and Bradford. This is an example of a strategic analytics segmentation model, and this is a primary care network. So as part of the NHS long-term plan, then the responsibility for population health management sits very firmly with the primary care networks, and so anything that we can do to work with our colleagues across the PCNs is really important. And we can slice and dice the data by deprivation, ethnicity, age, and this is an oncology one as well. Next. This is a version of some of the data that we used for the Academy. I'll cover some of that later, but we created a large synthetic data set that was of about 100,000 sort of patients based on a year of care, so that actually our Academy colleagues could see and use the data and do the modeling and actually learn the functionality of the system using the tools that are available and being able to access that remotely. Next. Once again, this is a very similar kind of one. We are using some of the cancer data set. That's fine, Rebecca, we can stay on that one. And then we've also done some data quality assessment. So the comprehensive patient record, you'll hear Jeff Hall talking about that. He's a consultant oncologist at Leeds Teaching Hospitals, and this is a large linked data set. And we, as you can see, 1.8 million records in here, and we wanted to know what the data quality is, and we also wanted to know the integrity of the data flow end to end. So both this this dashboard and the next one, please, shows some of the characteristics of that, and you can very easily sort of see what the the overlap in terms of treatment of chemotherapy, radiotherapy, and surgery are, and there's a huge amount of things that people can do in a very very attractive sort of way to be able to look at the detail without looking at crunching our way through sort of spreadsheets. So that's all I wanted to cover. I think I'm about a minute ahead of schedule, but that's pretty good. We're